on to part 2 discussion on temporomandibular joint disorders. The main three temporomandibular joint disorder which need to be discussed are MPDS, disc disorders and degenerative joint disease. MPDS is as a result of excess stress, muscular overactivity, dental irritation leading to muscle fatigue, myospasm as a result of muscle overextension and muscle overcontraction leading to MPDS, which further aggravates occlusal disharmony, internal dearrangement and degenerative joint disease in the longer run, altering the chewing pattern which in turn aggravates the MPDS cycle. MPDS is mainly diagnosed based on Laskin's diagnostic criteria stating that unilateral pain, clicking joint, muscle tenderness, jaw limitation are more suggestive of MPDS and is well managed with pharmacotherapy, physiotherapy supported with occlusal therapy only when there is obvious occlusal disharmony. Moving on to the next important disorder of temporomandibular joint, namely the disc disorder. Articular disc moves in synchronization with the head of condyle during normal mouth opening and closing. Once it gets detached, it either moves anteriorly resulting in anterior disc displacement, posteriorly resulting in posterior disc displacement. In case of anterior disc displacement with reduction, the disc remains anteriorly placed on closed mouth position, whereas it regains its normal position on opening the mouth. This is clearly seen in this MRI image of right side temporomandibular joint, where the disc is seen as an hyper-intense image lying anteriorly placed in closed mouth position, whereas it regains its normal position on open mouth position. Hence, it is diagnosed as anterior disc displacement with reduction. Whereas, in case of anterior disc displacement without reduction, the disc remains anteriorly placed both on closed mouth as well as on open mouth position. It is seen in this MRI image of left side TMJ, where the hyper-intense image depicting the articular disc remains anteriorly placed both on closed mouth as well as on open mouth position, hence diagnosed as anterior disc displacement without reduction. Disc displacement are well managed with just observation when there is only clicking and no pain. When there is obvious pain, it needs intra-articular corticosteroid injections and lubricants such as sodium hyaluronate. It needs occlusal therapy only when there is occlusal disharmony. Moving on to the last part of the temporomandibular joint disease, namely the degenerative joint disease, which is defined as non-inflammatory condition of the joint characterized by structural changes of the joint surface secondary to excessive strain on the remodeling mechanism. This is a tomogram of an osteoarthritis patient depicting all the salient radiographic findings in osteoarthritis such as flattening of condylar head, subchondral sclerosis, osteophyte formation and reduction of joint space. Moving on to the management of temporomandibular joint disorders, it is mostly self-limiting and it is well managed with pharmacotherapy for pain relief, supported with behavioral management starting from patient education, physiotherapy, spray stretch, supported with ultrasound, acupuncture and TENS to control pain, active splints, palliative splints and stabilization splints to achieve muscle relaxation and to achieve centric relation are advisable in case of occlusal disharmony. Usually, the surgical treatment is delayed and not recommended at the initial stage. Only when there is an obvious structural pathology, when normal functioning is impaired and the patient does not respond to medical management and when all contributory factors are controlled, surgical treatment is advisable. That too, initially, only minimal invasive surgery like arthrocentesis, gap arthroplasty are advisable. Condylectomy, meniscectomy with implant reconstruction are advisable in severe degenerative joint disease. While diagnosing temporomandibular joint disorders, the other conditions which mimics TMD need to be ruled out, mainly the odontogenic pathologies followed by maxillary sinusitis and other rare pathologies such as intracranial pathologies, ear pathology, Eagle syndrome, neuralgia, temporal arthritis need to be evaluated before confirming the diagnosis of TMD. Hence, the take-home message is that a TMD may be arthrogenic, myogenic, or occlusal instability. It requires multidisciplinary approach to achieve success of treatment. Most of the time, it is self-limiting, so it is better to do a evidence-based conservative management. Thank you.